celebrating our 20-year anniversary. Delighted to have you here today for our afternoon program. As I mentioned, we're going to be talking about the rules and hearing about it from a couple of different perspectives, provider, payer, and also a vendor. So we're going to hear all about how people are thinking about the rules, getting ready for them, and what this means for the future. For those of you who are not familiar with Zoom, right now we're all on Zoom. And you cannot speak, you're on mute. So we still want to hear from you, even though we can't hear your voice or see your pictures. We'd love to have your questions. Comments are welcome as well through the Q&A box there at the bottom. You're welcome to put stuff in the chat box, but the panelists won't be able to answer it. So if you have a question that you'd like to have answered, please put it in the Q&A box there at the bottom so that we can make sure we get to it. And we've got a lot of time for questions today. So we are asking as many questions as we have time for today. So please feel free to submit those in the bottom box there or any comments as well. Next slide. Again, I'm Jen Kovich-Bordnick, and I've got a really wonderful panel with me here today. I've got Drew Ivan, who's the Chief Product and Strategy Officer for Lineate. We've got Jeannie Tishy, who's the Director of Interoperability and Integration Solutions for Marshfield Clinic Health System, and Sagrin Moodley, who's the Senior VP for Clinical Data Services at United Healthcare. A great panel to start with. Next slide. For those of you who are not familiar with the Eat Health Initiative, we are a tremendous, wonderful thought leadership organization here in Washington, D.C., made up of an incredible group of executives. These are just a sampling of some of the organizations that work with us. If you don't see the name of your organization or company up there, we would like for you to join us. And we've got a lot of initiatives going on right now, which I'll talk to you about, but we would love to get you involved. So please feel free to reach out through the chat box. Send me an email, tweet, whatever you need, but I'd love to talk to you about how we can get you involved in our organization and in our efforts. Next slide. We primarily do education, advocacy, and thought leadership. And obviously you're here today because you're attending one of our educational programs, which we're delighted to have you on. We also do a number of executive roundtables, thought leadership reports, podcasts, all sorts of things, and different work groups. So we'd love to get you involved in those. So feel free to send me a chat and I will reach out to you. Next slide. Our work right now is centered around 4 key areas: virtual care, consumer privacy for health data, analytics, and of course, COVID-19. We've got a wonderful grant with the Robert Wood Johnson Foundation. We are developing a consumer privacy framework around health data, and we need a lot of assistance with that, what that looks like, how to self-regulate that. And we are in the 2nd year of that grant, so would love your involvement if that's an area you're interested in. Our analytics and social determinants of health work is really moving quite quickly. We've done a number of programs to date, developed guiding principles for how to use that data. And of course, virtual care, we've got a lot of programming right now on telehealth and virtual care and how that's being used around the country. So welcome your feedback and involvement in those things. Next slide. This is just a sampling of some of the recent forums and webinars. We are a nonprofit, so these are available to you free of charge in our resource center, ehidc.org, which I encourage you to go to, and feel free to download these slides or reports. Next slide. It's a sampling of some of the reports that we've come out with in the last 12 months. We've done a lot of work, again, around virtual care, social determinants of health, and COVID-19, and I encourage you to download and look at that material. Next slide. Couple of dates coming up. So today is not the only program that we're putting out there. We've got another great program coming up next week, March 25th, looking at SDOH data for the whole person. We've got patient matching, vaccination scheduling, lessons learned from COVID-19, lots of really interesting programs coming up virtually that we'd love for you to attend. As I mentioned, we've also got a roundtable coming up looking at virtual care in tribal communities. So if you work with any of those communities, if you're an executive that works with virtual care in tribal communities, or you have a client or somebody who does, please let us know because we'd love to include them in that executive roundtable coming up next week. Next slide. And I'd be remiss if I did not thank our wonderful sponsor today, Lineate. As I mentioned, we are a very small nonprofit e-health initiative, and we would not be able to put on these wonderful educational programs without the gracious, wonderful generosity of groups like Lineate who allow us to help promote education in our 4 core areas. And I'm really grateful for Drew and Lineate allowing us to do that today. So thank you, Drew. Next slide. Okay, now today's session is actually going to be primarily a panel discussion about the rules. I think everybody's read a lot of summaries about the rules, and what we really wanted to talk about today is how this is impacting payers and providers, and what is the field going to look like before and after this. So let's take down this slide if we could, Sarah, and let's just pull everybody up here. Welcome, guys. Great to see you. Good morning, good afternoon. So let's talk a little bit about what these rules look like. And I know that there's a lot of concern right now and people losing sleep over what this means for people. So I guess I'd like to just kind of start a little round here with, what's kind of keeping you up right now? And why don't we just go around, Jeannie, we'll start with you, but as a provider, and I know you're also representing a payer as well today, but tell us what keeps you up at night about these rules.
Well, I would say there's probably 4 things in total, 2 more short-term and 2 more long-term. So if I address the short-term pieces, April 5th, we really have to be in compliance with the information blocking. And I don't think we're unique in the fact that we are part of a system where we've acquired many facilities and organizations. We're up to 9 hospitals, and they're on disparate systems across the way. So we definitely are going to have to use the exceptions at this point in order to meet the information blocking rules. And there's a lot of work that goes into that and a lot of coordination. And that keeps me up at night, making sure all the different facilities on the EHRs are documenting these pieces and that they're prepared for if we would ever look at a complaint, that we're ready for it. And we also documented, the different ways in which we need to respond to requests for information. And in addition, as of May 1st, we have to be doing the ADT notifications out to the, if you have someone coming into your hospital, you have to notify their care providers or their primary care providers. And really that's kind of a loose statement. We need to make a reasonable effort to do that. And so, just making sure that we have met the letter of the law. If anybody would question that, it's a little bit loose at this point, but we're using the tools that we can. We have no responsibility for making sure they receive it, but that of course is our goal, is to get there. So we're at the mercy of the receiving end in order to make sure it makes it all the way through. And then long-term, because we have so many disparate pieces of information, in the end, we have 30 plus years of data, 10 different EHRs in which we want to be able to combine that and make the information meaningful to those who are going to receive it, deduplicate it, and all the effort that would be involved with mapping that data to each other and having it be meaningful to either a patient or a provider. And then finally, very exciting to have third-party apps to be able to hook up to our systems. And I think that's going to drive a lot of innovation along the way and improve a lot of outcomes. But we have concerns about making sure all the data is available, but also keeping it secure.
Yeah, there's always a but. Mm-hmm. Drew, Lineate is an organization that's helped supporting a lot of these efforts. What's keeping you up at night, and what are you worried about?
Yeah, so Lineate is making the tools that payers and providers will use to communicate with one another and also to satisfy their ONC and CMS rules. So we're really excited for this conversation to hear some of the topics that come out. What keeps me up at night is, in the role of a vendor, every place there's variability in the rule or in a standard, it means that that the provider or the payer, whoever's using that standard or complying with the rule, gets to choose one path or the other if they have optionality. But for the vendors, it means we have to support both, because we don't know what our customers are going to choose. They have the option to choose either, which means it's a lot of extra work for us. And so we expect that some of these options and variability will filter out over time as one gains prominence. But at this point, we can't really bet on one path or the other winning out. We have to support everything, which it's a lot of extra work for us. It takes a lot more preparation, development, and ability to support our customers and advise them. But we don't have the option to do just one or the other. We have to do both. And so for us, it's a little bit bigger lift, and that's what we're focused on.
So you're really having to customize this for everybody, depending on what their needs are. So Sagrin, so you are representing one of the largest payers, so this is really going to sock you guys, right? So what's keeping you up at night?
Well, first of all, good afternoon, or good morning, or good evening, depending where you are. Thank you for joining. This is a really unprecedented time, and I don't think I have to say that. I think it's very evident. But if anything, it only accelerates the urgency around this agenda. And so there's a couple of things really, all payers actually, and you know, it's safe to say that I've always been working with the provider partners and consumers and members to really figure out how to truly transform healthcare. And I say that in a broad statement, but I say that because we at a point where we want to be able to advance and improve decision making at the point of care. It's just the right thing to do. Now, specific to the rules, there's a couple of things that really are challenging. One is, as payers, we get data from a plethora of settings, from lab results to hospital notifications to provider settings, ambulatory imaging. We get all kinds of formats, all kinds of data. And if you know anything about, you know, the fact that the healthcare is local, data is local. So there's local codes. We do a lot of work around normalization, standardization of that data. Unfortunately, we got to just make that data available in its raw state, which means that presents the same complexities we deal with any other actor who needs to consume that data. That's number one. Number two, access, the who and the what is important, because we have to also have responsibility for or have oversight for who's allowed to see what. If you take 42 CFR Part 2 around substance abuse as an example, we've got to make sure that the consumer knows when they say yes, they're either allowing that substance abuse treatment data to be shared or they're not. And finally, I'll say that payers have a deep business and technical IP around dealing with large claims admin and clinical data and the synthesizing of that data, meaning order, refill, order, refill. We know that it's this event, this encounter, and this is the latest result. Making that data in its raw state available to downstream or upstream actors may not mean that they can, they can simplify the view, problem list, medication list, visit history, and care team. How do they take all this raw data, simplify it for consumer, and inform better decisioning for the consumer? So, that's it in a nutshell.
Yeah, a heavy lift, definitely. Jeannie, you mentioned that Marshfield is taking advantage of some of the exceptions, and I'm wondering if you can talk about that a little bit more to help people kind of understand what that means and what your plan is, and why you are doing that, and when you think you won't need to do that. Oh, you're on mute. No problem.
Sorry about that. Yes, we will have to take advantage of the exceptions, primarily because we actually had a homegrown cattails, it was called cattails EHR, in which we produced this 40 years ago. We created this EHR, And we knew we were moving over to Cerner as our EHR, and we're in the process of doing that, of converting. So we actually don't have the capabilities in our homegrown system because the investment into that to certify wasn't going to allow us to do that. And we also have systems like images and things of that nature, which just without having some of the infrastructure in place, we're in the process of putting that in place and creating basically a data hub where we have all of our information commingled together, but we're not there yet, and not for this rule. So as a result, we're gonna have to take in requests just like we do today, and where we can't actually meet the need, if they want it digitally, if they want to hook up a third-party app, we're really going to have some infeasibility exceptions, as well as the content and manner exceptions. So what that means is we're not going to set up FHIR APIs with our old, I should say soon to be legacy EHR. And where we wouldn't make those investments, it just wouldn't be feasible. And then with content and matter, we will be moving forward with responding to the person who's asking for the information and giving them alternative ways in which they can get the information. So always providing it, always meeting the letter of law of providing the information, but maybe not always in the way that it's requested. And that ultimate goal, the strategy is to get there, but that's going to take some time and some infrastructure that we're building in.
Drew, I'm curious if you can kind of piggyback on that a little bit. What are you seeing in terms of providers and compliance? Are you seeing a lot of people that need the exceptions at this point? What are providers looking for right now?
Yeah, they're looking for the tools to bring together the data from different systems where it might reside, because you know, in the ideal state, each hospital would have a single EHR and a single record for each patient and make it very easy to expose. The reality is that the data is not completely contained with one EHR. It's spread out across multiple systems, data warehouses, for a variety of reasons, some of which Jeannie covered. And so there needs to be methods and tools for pulling this data together and exposing it to the consumer as a single endpoint. In other words, the consumer or the mobile app that the consumer is using, let's say, doesn't want to make 10 queries into the provider system to get data from the 10 different systems that it might reside in. They want to make one API call and then have a component on the provider side aggregate that data from across the systems, deduplicate it, rationalize it, and expose it in a single response. That's a hard problem, but it's what the providers are being required to do, and so that's what a lot of our customers are facing right now and trying to build.
Sagrin, we talked about this yesterday, and you gave us a great analogy, kind of, about what's happening here. Do you think you could rehash that a little bit? Because I think it was great.
Yeah, you know, I call this the 110 plug model, right? So imagine, you know, all payers, and I speak from a vantage point of payers, we've always had APIs. We've always exposed these APIs to our partners and providers and consumers. But the challenge is, if you were on the provider side and you integrated with that payer's API, it means you maintained a host of them because every payer had a different API. And it became pretty complex, and you could never move to a pay agnostic model. You could never build an application that had an approach to you build it with one common endpoint or common framework, if you will, an API spec, and then what I call the travelocity of models, meaning you hit any payer with the same service. So Da Vinci, and I have a role in Da Vinci as chair, and Da Vinci and other HL7 accelerators like Karen and Gravity and Codex and Da Vinci are building the standards, right? You got to normalize the standard across payers. Otherwise, we'll continue to build on our own. But if you normalize the standard across payers and say that these are the defined implementation guide for provider directory or formulary or patient data or cost transparency, that becomes what I call the 110 plug. Because if we all expose the same 110 plug, regardless of the wiring to the electrical panel in our basement, meaning our basements would be our proprietary systems and databases, we call electricians in and we do the hookup to our basement, but we expose a standard 110 plug. And every payer, Humana, Aetna, Cigna, they all expose the same 110 plug. So now an application that's looking for provider directory calls the United 110 plug for the provider directory, and in the same way calls Aetna, Humana, Cigna, Blues, right? So this idea is we on a mission to expose standardization, i.e. in the form of these standard 110 plugs, that allows us to move to a pay agnostic integration model. And then if you flip it on the other side, and if you say that the ONC's mission around ER certification could create standard 110 plugs on the provider side, now for us to get clinical data out of the EMR and for us to share clinical data out of the payer side, creates an ecosystem that allows for innovation and unprecedented levels, because app vendors and application tools and productivity tools and care coordination tools, suddenly, if these plugs are standardized, guess what happens, right? I call it IT democracy, but everything starts to kind of accelerate.
Yeah. Drew, piggyback on this a little bit. So tell us how Lineate kind of helps people develop these plugs.
Yeah, we're the electricians that that connect the service panel in the basement to a standard plug. I mean, it's a perfect fit for the metaphor. We're the electricians and the tools that the electricians use, because what our tools do, we specialize in accessing data wherever it happens to be and exposing it through whatever format you need to expose it through. And so an example of that is to get data from an EHR and a relational database and any other system that it's in, combine it together and expose it through a FHIR API response. It's a perfect analogy. And I like the analogy for another reason, which is, you know, when electricity came out, the only use case was to power electric lights. But once standardized sockets were invented, it drove a lot of innovation. And so now we can have electric irons and fans and wireless routers because, you know, all of that innovation was piled on top of a standard, which would have been very difficult if there hadn't been that standard socket developed.
Yeah, I love that analogy. And obviously looking at the questions, people will get it. So thank you, Sagrin. I think it's going to take off. So Jeannie, kind of what's the barriers, I guess, to just putting these plugs in? Shouldn't it be easy?
Right.
It's the wiring in the basement, right, Jeannie?
Oh, well, there's a lot of there's a lot to this, to bringing all this data in. So it's one thing to bring all the data in, and it's also another thing to, I think FHIR standards are huge here in order to really talk to each other in the same language. So when we're looking at having all this data available and sharing information, that's really what we're being asked to do now. But even when we do that, from a provider perspective or a patient perspective, when we have all different types of EHRs and we're bringing that information, and it kind of, Sagrin kind of mentioned this, kind of having that normalization part integrated in here. And that's a big effort. That's about, you know, folks mapping this information to the standards, and FHIR is getting there. They have a lot of things that are mature enough in order for us to use that, but we're finding now we're doing what Drew suggested or had mentioned. We're a provider and we're looking to bring all that information together, and we're bringing things from Cerner and our system and Athena and all of these different places. And at the end of the day, when you have that information combined, you need to normalize on something in order to deduplicate it, in order to harmonize it, so that when you're handing it over to another provider or another patient, they're not having multiple points of data that really were the same thing. They just mean something different. So I don't want to interpret a say an allergy, a certain way, you know, it came across from somebody in one way and using their own code set or their own terms, and then somebody else, and patients nor providers want to have to take the time to actually sort through that. When you bring that data over, it's ideally it's matching because we're using the same language. And that's one of the barriers that I see, is really that effort to map things, and having all those standard code sets there. And FHIR really lends itself well to getting us all on the same page.
Segrun, what are some of the other barriers to kind of achieving this plugin?
So I think from the vantage point of payers, we got a lot of work to do, and we've been working on this journey. If there's anything we learned from COVID is we have to accelerate this work. You know, during COVID, I'll give you an example. We couldn't impose the burden on hospitals to give us notifications of inpatient visits, which we generally want, we generally do, because we do level of care and and inpatient length of stay reviews, and we work with provider partners around those specific clinical objectives. But during COVID, we had to forego the fact that then some notifications may not happen. I mean, we wouldn't have line of sight into inpatient visits for our members, and then appropriately plan. In fact, we would know about social determinant barriers, and would know about other extenuating factors around patients' complex chronic conditions, because we have that view about the patient. See, when you deal with clinical interventions, it's not about big data. Mm-hmm. Payers do a lot of work with big data, claims admin data. We do a lot of work. We have a lot of technical chops, if you will, data analytics on big data. But when you're talking about interventions, it's not about the average 65-year-old diabetic who lives in this demographic. It's about Betty Smith. So it's about small data. She's quadriplegic. She lives alone. She has mental health depression, and she's maybe having early signs of dementia. It's that small data. So the issue around, if you think about what the law is attempted to do, it's attempted to improve the quality and accessibility of information that Americans need to make informed decisions. And this is the 85 FHIR-25510. It's crazy that I know this because I have to live this. But that's the purpose. So even when we get to this level of compliance or connectivity, then what? Right. Then the job only begins. The fact that we connected is not the end point. The end point is, how do we allow consumers to make better decisions? How do we, about their care, how do we like providers to make better decisions about consumers' care? So, I worry about that. I call it, when connectivity happens, then it's game on. Like, then what do you do? Yeah. And I think it's a lot for consumers to consume, excuse the pun. This data will come in complex forms and shapes and versions. They'll see things in a chart that the nomenclature may freak them out. But they got to figure out how to normalize it and really rationalize it and I worry that Google becomes the second opinion.
Well, let me pick up on that with Drew, because Drew, you kind of alluded to this before when you said that, kind of this whole new connectivity is going to spur this innovation. Can you talk about, so Segrun's, speaking to that as well. What do you mean exactly? What will it allow to have happen? And what do you think about Segrun's idea that this is going to kind of open up the...
Yeah. We don't know yet. Isn't that exciting? We're putting the infrastructure in place on the faith that innovators will finally be able to unlock the data they need to drive novel applications, and that are the technologies in place today. The only thing we need is the data to power them, and that's been a big obstacle. And it's one that healthcare IT vendors have been trying to overcome for years. And right now, it's possible when they're sufficiently motivated, right? There are ways to get data about a patient and use it to drive an application, but they tend to be expensive, complicated, and vary from site to site or data source to data source. And by standardizing that, you really lower the bar on making that data available to the app developers to do innovative things with. And what will happen when that next tier of applications is available? We don't know yet, but it will be exciting. It'll be risky. There will be misuses of the data that will slip through and that we have to react to. But I mean, with every challenge or every risk, there's also potential upside, and that's what we're counting on, is the innovation that will be driven by the standard methods of accessing data. That'll be really the missing ingredient for all of this technology to be unleashed.
Jeannie, maybe you could speak to this a little bit more. We've got a question about this as well. You know, what are your concerns about these patient-facing apps and third-party vendors being able to gain access to patient health information through the APIs? You know, what are you worried about? What can you control?
Worried about? This probably one of the biggest thing is what I mentioned earlier, and that's really how are we making sure that data stays secure? And then beyond that, we have a lot of organizing to do on our side on how we want to present this. Are we going out actively to identify certain apps that we think will help someone with congestive heart failure or diabetes? To wait for patients to come to us and say, I have a third-party app, it's probably a better situation to improve outcomes, to patient outcomes and patient safety, if we are engaging, having the provider and the patients improving their relationship, as providers can recognize apps that will help them better take care of their patient and really advocate for it. I think that's really the avenue of where we're going to see this take off, and where we're going to see our patients see the value in interoperability and really understand that this is what we can do for you. And having, one digital front door is wonderful, but we have to bring all of that information together on our side and make sure it's secure, make sure we have in place the right filters along the way. One of the exceptions about sharing information that really is controlled now, because some of this stuff is manual, but preventing harm, not sharing information before a provider can actually share those results, because it might not be good information to share just right out of the gate. So there's those are some challenges that we're going to have to build in to make sure, we can have everything available, but there are going to be situations that we have to account for to make sure we're being careful about the safety of the patient, the privacy of the patient, and their data.
We've got a great related question here, Sagrin, about from one of the participants. I can relate to your concerns about this, but when this is achieved, what about the care coordination, care management, and patient engagement value for your members and payers of these third-party applications? Sagrin.
What about?
Yeah.
I think it's the mission, right? I was touching on it a little bit earlier. We have to transform healthcare delivery, and I call this frictionless experience for consumers and providers. I mean, it's still too choppy. The experience is choppy, right? I mean, can you imagine that even today, if patients navigate between care settings, their documentation and electronic medical records don't flow? It's crazy. So I absolutely am thrilled, because I always say providers don't know what they don't know. They don't know that the patient is a snowbird, went to another state a few months of the year and had visits in another state and then come back, right? As payers, if there was a claim, we at least know there was an encounter, and then we can help orchestrate and stitch together those events and then share it with the provider. Because now when the provider sees the patient, he can say, oh, Betty, I see that you saw Dr. So-and-so for this condition in Florida. How did it, right? I mean, so I'm jazzed about the opportunity that we need to do this. It has to be done. It's long overdue. And in other sectors, we have a very high or very low tolerance for lack of this exchange or interoperability of, in fact, I always say the fact that we still talk about interoperability in healthcare is a bad thing. Because in finance, you don't talk about interoperability. Like you don't, it happens. You go move money from bank to bank and across the state, across the country, and it happens. And I look forward to the day when we don't talk. It's so important and it's such a cornerstone that we shouldn't be talking about it. Meaning it just happens, right? So I look forward to that day because that really means that to the question, care management activities, care coordination activities, transitioning care, follow-up care, preventative care, all those things can happen for the we can't control healthcare spend and outcomes and the triple aim and patient satisfaction if we don't do that.
Well, so it sounds like this compliance or standardization is going to cause a lot of disruption for a lot of different groups and a lot of different reasons. What are some of the benefits, though? I mean, Drew, can you talk about kind of what this means a little bit for the consumer? I mean, what are the positive pieces here?
One thing that it means is that the consumer becomes the point of aggregation for data about themselves. So, every consumer, every person, gets their healthcare from one or more providers. They probably have one payer, but at a time, but multiple payers over a period of years. And then when you think about other data, like any type of wellness apps that they have or personal fitness devices, all of this data is different views on the same person, and it belongs in the same app so that the logic can run across all these different data sets. It doesn't make sense to try and aggregate everybody's data in a big silo. You don't want all the providers' data from all the providers, all the payer data from all the payers, and you especially don't want like all the personal data from people's Fitbits and Apple Watches in one massive database. But for each person, they might want their own view of all that different data. And what these rules do is enables the patient, they're already generating data about themselves on their mobile apps that's already stored locally. It lets them pull down that data from their provider and from their payer to combine with their other data locally and drive all kinds of new use cases. So we don't know what they all are yet, but I think some of the low-hanging fruit is going to be around chronic disease management, around precision medicine. These are things that are rather ambitious projects and very difficult to do when you're talking about a single database that has everybody's data from every source in it, but start to make a bit more sense when you push the logic out to the patient's device and let them operate on their own data. And so that's what I see as the disruption.
So Drew, could a patient potentially get all of their EHI information through a third-party app instead of through their provider? Like the notes and their complete record, would that be possible? Or would they still have to go through their provider potentially?
Technologically, it would be possible, but I think that the third party would be then accessing the provider data on the patient's behalf. So okay. It would introduce another intermediary, but that might be just the thing that you want if it's aggregating data at some level.
Yeah. Interesting. So this is an interesting question here. We've got great questions here. Guys, if you have questions, please add them to the Q&A box. This is really helpful for the discussion here. So would denying access, Sagren, to one of these third-party patient apps, is that going to be considered then kind of an information blocking?
No, I think it's the patient's data and it's our members' data. And if the member consents to the sharing of their information, as payers, we would share it, right? I think I think that the challenge has always been around this concept of covered entity.
Mm-hmm.
So in the ecosystem of providers and payers, when we share data, it's under HIPAA, and those express requirements around maintaining HIPAA and PHI. But once you share the data outside, I think consumers really have to know it could be a single trapdoor. That when they share
what do you mean?
when they say yes in that app,
Mm-hmm.
that data is gone. It's not under HIPAA, under covered entity anymore. And when they said yes, you can please share my information with app vendor 1. When they say yes and we share it, they got to understand what the app vendor is going to do with the data.
Right.
And that is the caution I would and this also this education, innovation is fantastic, right? I mean, it creates opportunity, but it also needs you need to ramp up education on what does this mean for you. Just like all other forms where we integrate and socialize in other electronic forms through social media and everything comes with a caution.
Right.
How will this be used?
Right.
Whether you in Facebook or whether in any other application, social media application, the same applies here. When you say yes, share this data with this vendor, and we will do that on your behalf. What are they going to do? Is make sure you understand what the application or what the vendor is going to do with it, including marketing for other purposes and a host of things. And I'm not saying I'm not saying there are bad actors out there. I'm just saying consumers need to be aware.
Yeah, I mean, I think, Jeannie, I see you shaking your head. I mean, I think this is what we're all concerned about. And we're talking about really notification of disclosure. So does the patient realize what's going to happen to their data once it goes into that third-party app, which we hope is, doing the right things with their data appropriately? Right. What are your thoughts and concerns, Jeannie?
That is one of the biggest items of discussion right now with our security and compliance, and really trying to develop what is our plan for bringing a third-party app into the fold. How far do we go with that? Are we looking at how they keep the data secure when it's at rest? What happens when it leaves our door? And I think the rules sort of make us not responsible for what that third-party app is. We're supposed to accept, the request and fulfill that request, but we're very concerned about that and being associated with something that might, while maybe not responsible, that's not exactly the press you want to be associated with. If you've associated with a bad actor or someone who hasn't an app that hasn't, or an app developer that hasn't taken the steps to make the data secure or does something not appropriate.
I think it's almost like, providers and payers have been kind of the parents or the guardians of this data. And now we're letting our children kind of out into the world. And what's going to happen with them is what's going to, they're on their own at this point. So there is a lot of concern, I think, with providers and payers about what's going to happen once this information is released out there. What can providers and payers possibly do, Sagren, to inform consumers or help them understand what this means?
Education is going to be important. I'll give you one example. In the regulation, there's a 42 CFR Part 2, which talks about substance abuse treatment. I think I may have mentioned it. And so when you say share my data, you have to know for sure that does this include substance abuse treatment? And we need to know that. because when we share that data, there's some data. In fact, some states have varying degrees of regulation around what we call protected data classes, HIV/AIDS, substance abuse, mental health, those things. And so I think we're going to have to look. Innovation is phenomenal. It has to happen. It's important to create what I call that level of transparency and consumer empowerment. I want to be able to make decisions. I want to be able to see cost up front. So cost transparency and all those things are right things to do. But it's going to put more burden on ownership on the consumer to be informed about when they participate in this new way of engaging and interacting with other actors and vendors and stakeholders. How do they, how aware are they about what the participation level is and what's going to happen with their data?
Drew, do you feel like the providers and payers that you're working with understand this fully? And what's kind of are you having to educate them about what this means and what this is going to, the impact it could have, or do people have a good sense of this out there?
Specifically around the data leakage?
Mm-hmm.
Yeah, I think the providers and payers mostly understand the issues related to that. And I mean, they want to be good stewards of the patient data that they're capturing. So they're being very conservative about the ability to let it out. And that's a big concern with these rules. It mandates that the data has to be shared unless there's one of those 7 or 8 exceptions. And so I think that they're very worried about the unforeseen, or in some cases foreseen, consequences of what that could mean. I think the education aspect is the only way to attack it. I think that most patients don't really understand HIPAA and what it means, but they sort of understand that healthcare data is protected and is not supposed to be disclosed under any circumstance. I think they also understand what it means to have data on their phone, on their mobile app, because they do it in so many other scenarios. But I think they don't really understand how much of that data is repurposed and repackaged and used for secondary purposes that they didn't anticipate when they agreed to share that data. So I think when you combine those two incomplete understandings, there's a lot of potential for things to happen that the patients would not have wanted to happen if they had been able to think it through properly. And so I think there does need to be that education, and it has to be broken down to a very basic level, because just pointing people at the text of the HIPAA law and the text of the CMS regulations is not going to be manageable for most people. There needs to be some common sense explainers, and I think ONC has some of those on their website, but I also think that most patients aren't going to the ONC website to try and figure out exactly what the implications are of this new capability they want to take advantage of. So it feels to me like the best place to put that education is closer to the provider, since they are the ones that have the closest relationship with the patient. Payers do too, but I think most patients would rather be educated by their provider rather than their payer. But really, wherever the information comes from, it's going to be valuable, and it's going to be a key piece of making this successful.
So Sagar and Jeannie, as provider and payer, do you envision having kind of just an opt-in for sharing information, or having some role in the vetting of some of these third parties? Sagar first.
Ladies first.
Jeannie.
So, and I want to make sure I understand your question. You said, would we be in favor of an opt-in for the?
Just kind of a general opt-in for all patients to just share information with third parties.
Sure. And I think it depends on your state laws and rules. Certainly it has to be, when it comes to third-party apps and the patient, that has to be initiated by the patient. and that's how they would start their identity and hooking up to our system, whatever system we elect, our hub of information across the way. So, you know, in Wisconsin, where I'm from, it is an opt-out state. So we do, as far as other pieces of information, when it's to provider or to payer, we are sharing that information unless we have gotten consent or been told by the patient that they need to opt out. As far as the third-party apps, I think we're looking at really them, again, advocating for whatever app they want, but I would love to see our working with our providers and identifying a group of apps that help, you know, not just for the sake of having a third-party app, but actually give us back we realize some benefit from it, whether it's safety, whether it's decreased hospitalizations, things of that nature that would help us along the way, decrease costs. I recall, and it would be great to have the patient have that with them. I recall I used to work in the radiology group, and one of the biggest contentions was when we got an emergency case or a trauma case, they were strapping the CD of the image to the patient, you know, as they flighted them over. You know, if patients are giving access to that information to their providers and have apps that actually share between the patient and the provider, we would be in great shape. And that would lower costs, that would keep us from doing imaging unnecessarily, but providers need that information, and it would be the patient sort of being the stewards of that information. They need that information right then and there to make good decisions, good quality decisions.
So Sagrin, to you, so as a payer, would you push out an opt-in request to all patients to be shared with any covered entity or to third parties?
I mean, it's the same. We have to. It's specific to the federal and state mandates and regulations, and that's the overarching. You know, that's the overarching protocol for what we do around opt-in. So whatever the state mandates as the opt-in or opt-out approach, and it varies from New York. It's very much everyone opts in, even in HIEs. It's not an opt-out to all the way on the other side. So it depends on the state, and it depends on, you know, in this particular requirement is very defined mandates around the authentication, what's called OAuth certificate authentication for the consumer.
Drew, how are providers and payers going to authenticate patients when they connect through apps?
Yeah, that's a great question, because you know, what the infrastructure will enable is that any patient can request their data from whoever's holding the data, but how does the data holder know that the person requesting the data is who they say they are? Right. Because you know, otherwise anyone could request anyone's data. So there needs to be the identity verification piece, which, you know, we've seen examples of that. If you've gotten your credit report, they ask you a series of questions about places you've lived or loans you've had that theoretically only you're supposed to know. That's one way of making sure that the requester is who they say they are. There's other schemes that involve, like submitting photographs of the person requesting the data and their state issued ID. And then, you know, on the back end, that's manually matched up. So I think there's, you know, a lot of that work to be done. There's also work to ensure that once the identity has been established, that it's an authorized application requesting that information on behalf of the authenticated person. I think it's not easy, but it's something that we've solved in other fields, and therefore there's hope that it can be applied in this field as well. And it kind of layers on top of something that Jeannie said that I really love. I like the example of strapping the CD to the patient when the care is transferred. The reason why that's done is because there's no better place to put the clinical data than physically on the patient. And the fact that you have to do it through a CD or through a paper chart is extremely inelegant. And I think what we're looking toward is a more elegant way of doing the same thing by putting it not, duct taping it to the patient, but putting it in a mobile app that they carry with them. I think that accomplishes the same thing of putting the data with the patient in a way that's much more manageable. And there was a question in the Q&A about that architecture with regard to security, which is how this all comes back around. I think an advantage of that is if you make the patient the only point at which all that data is aggregated, it's much harder to hack that, because instead of hacking one database and getting 1 million people's information, to get the same 1 million people's information, you'd have to hack 1 million mobile devices. It makes it a much different problem. And so there's a lot of reasons why making the patient the point of aggregation and the place where transfer of care style of interoperability occurs. There's a lot of reasons why that makes a lot of sense. We just have some technical hurdles to clear before we can get there.
Well, let me just ask this as a follow-up, Drew, because I mean, it seems like a lot of support's going to be needed to do this piece. Do you see that as falling on, who's ever the provider or the payer who's that burden to do that? Because someone's going to have to fund that and create that, or is that kind of the third party group, or what do you?
Yeah, ultimately, I think they're responsible. I think that there will be a variety of technology solutions, and as they become standardized, they'll become more repeatable and lower cost. I think we're the problem right now is as bad as it's ever going to be. From here on out, it's just going to be improvements until we get to a point that maybe gets to where Sagarin wants to be in terms of interoperability just happening. I mean, that's the ultimate vision, but we're still in the very early days of that journey.
Well, we've only got a couple minutes left, so I'd love to give each of you a moment to help us end on a more positive note. So I asked you at the beginning why you're losing sleep. So let's spin that around a little bit. How is this change or disruption going to actually benefit patients? I mean, how do you see it changing healthcare? Give me some of the positive impacts of this. Jeannie, why don't we start with you?
Sure. This can have very large impact as far as the patient safety, the data accuracy. When you have patients seeing their information and being able to respond to that, our providers are going to have better information. They're going to be able to make better decisions because they have confidence in that data as well. When you have things coming from different systems, and no one really, the right person to mediate that and look at that is the patient, and having it in their hands is a huge benefit. I've talked about, the lower costs. I've talked about basically that better coordination, efficiencies of getting data from one place to another. There's, in fact, even just people themselves and release of information, and maybe getting rid of those fax machines along the way would be wonderful.
Sagarin, your thoughts?
I'm bullish. EMR adoption is high. Federal reforms driving mandates, HL7 standards, value-based care. The public health crisis is accelerating. Telehealth and remote patient monitoring. It's an awesome time. But here's the thing: we have the ability to change it for generations to come, not just now. And that's the impact we'll make.
Thank you for that. Drew, give us some positive thoughts to end on.
Yeah, I'll just say that sometimes it's overwhelming to look ahead to how much further we have to go, but it's also useful to turn around and look at how far we've come. I've been in healthcare IT for a little over 20 years, and when I started, it was rare to have an EMR implemented in a hospital. The records were on paper, and it was the minimum that the doctor could write and still get paid. That was the state of the art. And today we're talking about, how do we unlock this rich source of data in the providers and in the payers and put it in the hands of the patients. And, I could not have even conceived of that question 20 years ago. So we've made tremendous progress, even if we have a long way left to go.
Great. Well, I want to thank Jeannie, Sadran, and Drew today for our discussion. We've gotten so many great questions. I wish we'd gotten to them all today. It's clear we need to do this again, so we will. I hope you join us next week for our next webinar, and we will be having many more webinars talking about this. Thank you, everybody. Have a great
Thank you.
afternoon.
Thank you.